Hi, everyone. My name is Craig Hofmeister. I'm talking to you from Atlanta, and I'm very excited to be here. I'm going to try sharing my screen and see if this works. So I want to tell you briefly about myeloma bone disease, talk about neuropathy, and IMiD-related rashes. So I also have all the slides that I'm going to be sharing with you are all online. You can look at them yourself, and they're part of a Google Doc folder that I have. So please feel free, and also feel free to contact me via email if there's any questions or concerns. So myeloma is certainly not something new. In fact, this skeleton here shows what we believe to be myeloma-lytic disease, and it's one of the oldest skeletons found where it's, cohorted from the same time, did not show these lytic spots. The lytic means essentially holes in the bone. Myeloma bone disease is incredibly common. It occurs in greater than 90% of myeloma patients, and many patients, the majority of them, have pain at the time of diagnosis when things are really at their worst. Bone destruction can involve any vertebra, but remember that the majority of your bone marrow is in your spine and pelvis. So that's where most of your pain is, and lower back pain is the most common presenting pain symptoms that myeloma patients have. Now, a little cartoon, because I don't learn anything if it's not a cartoon. On the left side, you see an osteoclast, and this is a multinucleated cell that is picking up these bricks. The guy on the right is the osteoblast. He's laying down new bricks. And remember, this process of picking up old bone and laying down new bone happens all the time. It happens a whole lot faster when you're 18 than it does when you're 70, but it's still an ongoing process. Your bones are really alive. In myeloma, half the maintenance crews essentially sent you their out-of-office email, and they won't be doing much work. So you can see on the left-hand side, you have good normal bone, whereas in the myeloma, the osteoclasts are chewing through bone stimulated by the adjacent myeloma cells. And what they do essentially is rev up these osteoclasts to pick up the bricks of your bones without stimulating the osteoblast to lay down new bone. And what Zomeda does is essentially turns down the osteoclast and makes it difficult for them to pick up old bone. And what Xgeva does is essentially starve the osteoclasts of energy or from stimulation from these myeloma cells so they're not so revved up. If you have myeloma bone disease, there's a lot of things that can be done to decrease bone pain. So you can get local radiation. This is a local solution to a local problem. It's not going to work in your entire bone. We can't radiate all your skeleton, but we can radiate particular spots at particular times. Kyphoplasty or vertebroplasty we'll go over later. This is where essentially cement is injected into the vertebra to decrease pain, but it also decreases the worsening of the compression fracture at that vertebra, and it can be combined with radiofrequency ablation of the nerve at that spot, so it also improves pain. If you have long bones, they can put nails inside the bone to stabilize that bone. And certainly pain medications can be used anywhere from NSAIDs to lidoderm patches to opiates to adjuvant neuropathic pain meds. A lot of them are certainly possible. NSAIDs are not commonly used in many myeloma patients because we're always concerned in patients who are a little older, who are more at risk of NSAID-related side effects like stomach ulcers and kidney dysfunction. And ultimately, bisphosphonates decrease fractures and aren't really active in terms of decreasing bone pain. So the two procedures really that are available and are often available in an institution-specific manner is a vertebroplasty, where basically they simply inject in a cement-like solution into a collapsed vertebra. And kyphoplasty is where you have the same collapsed vertebra, but instead you put in a balloon and then fill up that balloon with cement to stabilize the vertebra. And long bones, you can see this long intramedullary nail on the left-hand side that'll stabilize a fracture, and often with screws on the outside for bones that have a very long or large hole related to their myeloma bone disease. Zomeda overall, this is a complex chart. Once you look at it, on the left-hand side, it's your bone stabilizing effect and what you can use for patients with osteoporosis and what can you use for patients with myeloma. I often get a question, well, why is it that in osteoporosis they tell me to use a lot of Fosamax, but I don't hear about Zomeda and Exgiva? Basically, it's because these drugs, when given in a myeloma-related sense, you're giving them monthly, whereas in osteoporosis, these are given just once or twice a year, and Fosamax or Beniva and other agents are often given on a daily basis, but they don't have a significant bone-stabilizing effect in comparison to the way that myeloma bone disease rages in most of our patients. So limits, I think people often have the misconception that these drugs, form new bone and will repair everything. And really what they're known to do is decrease risk of fracture, but they really don't prevent all fractures, they don't build new bone, and it doesn't really allow patients to heal their lytic bone lesions. Their claim to fame is that they decrease risk of fracture, and that's why we use it in patients with poorly controlled myeloma bone disease. So this is where it gets a little bit, what we don't know about these agents is really how often to use them in exactly which patient, because it's hard to do these studies, they're expensive, and they go over long periods. So overall, we know that Zomeda and Exgiva reduce fractures in patients with myeloma bone disease. But we also know that if your myeloma is well controlled, these agents don't provide that much assistance. So if you're starting treatment, we recommend using intravenous Zomeda until your disease is well controlled, which means achievement of a very good partial response or better. And then we tend to hold off on further use of these agents when the myeloma is well controlled. Exgiva and Zomeda are approximately equivalent in terms of how effective they are, but Exgiva is overall safer if your kidneys have been significantly affected by your myeloma. So we often will do Exgiva subcutaneous monthly for patients with myeloma bone disease and poor kidney function. Exgiva is a little bit more of a strong agent, and therefore some patients do better having boosting up of their vitamin D and calcium so that they don't have a significant lowered calcium level after exposure to Exgiva. So oftentimes we'll put Exgiva along with vitamin D and calcium together to prevent a relatively common side effect of low calcium levels in myeloma patients that can rarely become symptomatic from these low calcium levels. At each relapse, we recommend that you use Zomeda or Exgiva, again, based on their kidney function, until the disease is controlled, and then you can stop these medications. The big risk is osteonecrosis of the jaw. So if you have not had access to good dentistry, and then you get exposed to Zomeda or Exgiva, which really seat in your bones, and your teeth are bones, and then you have an extraction. This is the #1 risk factor for osteonecrosis of the jaw. Osteonecrosis of the jaw looks like this. This is an area of exposed bone in the gum. You can see a cross-sectional view here where it kind of eats away. This used to be, had people scraping this bone and oral surgeons doing more things, and actually recently we found that doing less is better. And the biggest risk factor is pulling out a tooth. If you must have a tooth pulled and you've recently got Zomeda or Exgiva, we often recommend that you take some chlorhexidine mouthwashes to try to decrease the risk of developing osteonecrosis of the jaw. And if you develop this risk, in general, we don't try to expose you again to Zomeda or Exgiva because the benefits are unlikely to outweigh the risks. Okay, that's the first one that I wanted to talk about. The next one is about neuropathy. Neuropathy is absolutely a dreaded complication of myeloma therapy, in specific because myeloma patients who develop neuropathy both have specific drugs which cause neuropathy in a specific manner, and there's usually a specific way to treat it. So how does it start? It's usually just tingling, hands and feet. It's a little bit like diabetic neuropathy because it affects some of the same spots in your body. Really, bortezomib or Velcade attacks the part of your spine just where the nerves come out of your spine, and that's where all the action happens. And by the time these neurons get to the tips of your fingers and toes, that's where you get the sensation. First it's tingling, then it's cold, and then it's more tingling. My patients will tell me it's like when your hand falls asleep if you sleep on it. Then it's numb, and people will say they're like walking on foam. Eventually it can be numb and painful, which sounds crazy, but you can actually have hands and feet that you can't feel but still hurt you. And most of the time, it starts off slowly. You're getting your dose of Velcade either weekly or every other week or twice a week, and then you develop some tingling. And then it's cold, and then it's numb, or cold first, then tingling, and then numb, and then pain. And usually it builds up slowly, so that if you communicate this with your oncologist or nurse practitioner, whoever you're working with, and say, hey, listen, I'm noticing some tingling, early communication is very, very helpful. If you're 5 cycles into getting Velcade twice weekly, you're not going to get Velcade-related neuropathy, no matter how much you get. And people often ask, well, if I get neuropathy from the Velcade, when is it going to get better? And it really continues to get better. It starts getting better, has an opportunity to get better at least once you stop the Velcade, and then after 9 months from your last dose, it's not going to get any better. Whatever you have at 9 months is really the bulk of what you're going to remain with. Thalidomide seems to be more long-acting in terms of its neuropathy, and most other agents that we use currently don't cause a lot of neuropathy. So in general, if you have tingling and numbness, I will try to avoid giving you thalidomide or Velcade because that just sounds terrible. And I usually recommend, even though at the beginning we reduced the amount of Velcade we give, now we try to reduce the frequency first, then the dose. And it hurts a little bit for us to do that from the oncologist side because we don't like to reduce the dose of Velcade because dose matters. A higher dose of Velcade, a higher dose of Kyprolis, a higher dose of Nilaro, all are associated with better activity. And ultimately, many of our patients are getting Velcade-related, Velcade-containing drug cocktail when they're initially getting treated and then move on to transplant. And if at the end of your 4th cycle or 2nd cycle or 6th cycle and then you're heading towards transplant and your neuropathy is getting worse on a daily basis, I recommend not moving forward with stem cell collection and transplant because both the Neupogen or GCSF used to collect cells and the melphalan at that time tends to amplify the neuropathy. And I usually will delay transplant in those patients until their neuropathy is better. There are, as you can see on the right-hand side, there are a lot of things on the internet, if you use Google or other search engines, that people will tell you will improve your neuropathy, completely clinically proven, no side effects, guaranteed. Whenever you see this, please be very suspicious. All of these vitamins, most of them have been proven not to be helpful in treatment, and no studies have really looked at prevention in a specific way. Alpha-lipoic acid specifically has been looked at And again, just to work on the fake news, it does not prevent Velcade from working. Neither does green tea, vitamin C. None of those things can be taken to patients. These, in general, are not successful at either preventing or treating patients with peripheral neuropathy from Velcade or thalidomide. Non-prescription interventions that might help, there are two things. Acupuncture can help. There was a small study, really about 20 patients that patients got acupuncture twice weekly, then weekly, and it tended to improve things, but it was a small study. It wasn't randomized between acupuncture and non-acupuncture, so we're not really sure. A lot of my patients, this is something they consider, but often something they can't afford. Massage, using compression stockings, cocoa butter, any kind of mechanical manipulation of your hands and feet usually provides pretty temporary relief, but usually actually people say it does help a little bit, but it's short-lived. For prescription medications, in general, the things we try to do are change the pain threshold in your brain using either Cymbalta, Neurontin, or Lyrica, and then reduce the pain transmission using opiate medications. So Cymbalta is our preferred if insurance is not a barrier, and Neurontin is our second line. Usually start dosing the Cymbalta at bedtime and then do it twice a day. And you'll try to do Cymbalta up to 30 milligrams twice a day, and Neurontin or gabapentin 300 milligrams 3 times a day. Once you get up to that dose, if you don't see any benefit, that drug's not going to work, and you can try one of these other 3 drugs to help. Often 2 of these drugs together, and we know this from diabetic neuropathy, work better than 1. So if you can combine them without too many additive side effects, that's ideal. And then you can often test whether your neuropathy is going to get better using an opiate like oxycodone as a short-acting opiate that's cheap. And then if you find benefit in the addition of using oxycodone, they can switch to an extended-release drug like MS-Contin or methadone. The dosing of these drugs is a bit of a challenge, and people get nervous for obvious reasons about using opiates. And fear of addiction really can lead us to undertreat our myeloma patients' pain, and that's certainly not what we want to do. But we do want to use it appropriately and look for patients who are less likely to tolerate opiates and proceed accordingly. Okay, I have one last group of slides, and I hope you'll stay with me here as I zoom through complications. So rashes and shingles, everything skin related. Rashes for thalidomide, lenalidomide, pomalidomide, these are usually large areas. You can see Caucasians, African Americans have these, kind of big areas. Usually starts within 10 days of starting or even restarting an IMiD, and this is one of the few drugs where a rash does not mean you're allergic. I know you've heard that for every other drug, is that if you get a rash, you're obviously allergic and you shouldn't use it, and that's not true. In fact, I've never met a myeloma patient I couldn't give an IMiD to. And so what happens for most people is that they start taking, let's say, Revlimid, and 3 or 4 days into it, they notice a rash, they call their doctor, and what we usually say is stop taking the Revlimid and start taking a non-sedating antihistamine, something like Claritin, Allegra, Zyrtec, whatever, and wait for the rash to start getting better. Once it's getting better, kind of under the cover of Claritin or other agents, then you usually can restart the Revlimid. Most people do fine. Some people, either the rash doesn't improve and they need a little steroids to kind of jumpstart resolution of the rash. And then in about less than 15% of patients, they get re-challenged with the Revlimid, and again they have the rash. And that usually means you need to dose reduce, and usually you can get the IMiD into the patient at that point. There are a very small number of patients where even if they dose reduce, even if they're under the cover of Claritin, they still have a significant rash. Those patients, you really have to just personalize the dose and say, okay, let's try taking Revlimid twice a week to start and see if we can get that. And if we get a week where it goes okay, now we can do it 3 times a week, and then 4 times a week, and then 5 times a week. And usually they'll kind of find their way to just the right dose for that patient that doesn't allow them to have a rash and does allow them to have a therapeutic IMiD experience. So I think every patient can get through a rash. It just takes some work. Shingles. So older than age 50, it puts you at risk of having shingles. Any immunocompromised patient is at risk of shingles, and shingles can precede, in terms of months, the diagnosis of myeloma. So it's not uncommon for patients to have shingles 8 months prior to presenting with symptomatic multiple myeloma. The risks just from having myeloma, that puts you at an increased risk. Velcade and really, we assume, any other proteasome inhibitor, Ninlaro, Kyprolis, both can increase your risk of shingles. Darzalex increases your risk of shingles. And finally, CAR-Ts, because they can cause prolonged immunosuppression, they can also increase your risk of shingles. So shingles is absolutely a rash you don't want to get. And prevention is usually pretty easy. We usually give acyclovir once a day for dialysis patients and twice a day for everyone else. You can give Valtrex or valacyclovir 500 milligrams daily, but it's a significant cost differential for most people, so we tend to use a lot of acyclovir. And myeloma patients, Shingrix is available for those patients greater than age 50. You usually do 2 doses, and we usually recommend doing this either a year after autologous transplant or after being on single drug maintenance for about 6 months in those patients who are not moving forward with autologous transplant. We know that Shingrix can work even 3 months out from autologous transplant and is quite effective in patients older than age 50, but we don't necessarily know how well Shingrix is going to work if you're on 3-drug, continued therapy with Darzalex and Revlimid or Darzalex and Kyprolis. What does that mean? There's just not a lot of data regarding your shingles protection at that time. So many of those patients who are on multi-drug maintenance are often continued on acyclovir because shingles is just really not a rash you want to have. Shingles treatment, usually we give higher dose acyclovir. Again, it's a little cheaper than the Valtrex, but you do have to do it 5 times a day. If that's too much, then you can do valacyclovir Valtrex 3 times a day at 1 gram. Special note is that just be careful if you note this rash in and around your eyes and ears. This is a big issue, and you really want some expert involvement because you don't want to have this cause visual loss of your eye, which is possible. So any rash in and around your eye, you want to seek immediate attention with expert evaluation with ophthalmology, getting potentially steroid eye drops and intravenous acyclovir to be sure that it doesn't cause any troubles with your vision. Okay, that was my quick review of some supportive care and quality of life problems. I'm passing this back to the rest of the crew and look forward to the Q&A.